All right, thanks everybody. One more talk before we break, and we'll also have a roundtable discussion to go over any questions you may have. My name's Stephen Leckie. I'm a spine surgeon with Plymouth Bay Orthopedics, and I will be talking about computer-assisted navigation in spine surgery. I started taking an interest in computer-assisted navigation after a few years in practice when really the carpentry of placing pedicle screws by freehand technique had sort of lost the allure that it used to have, and I just wanted the screws to go in quickly and safely and be perfect every time. And I was beginning to become a little bit nervous about the radiation exposure that myself and my staff were being exposed to in the operating room. So this can never happen. Something like this would be obviously neurologically devastating, and although even with freehand technique, a misdirected pedicle screw like this would virtually never happen in experienced hands, anything that is done by humans has a rate of human error, and so pedicle screw placement is really on a bell curve where the vast majority of them are good, and then some of them are acceptable, potentially a slight breach, but then there will be outliers, and the goal is to eliminate those outliers, and that's where computer-assisted navigation can really be useful, where we may not have needed it for 99% of those screws, but to eliminate that one devastating outlier, it would be worthwhile. There are a variety of computer navigation platforms available. This is what we're currently using, the Brain Lab, the AeroBed. This is an intraoperative CT scan, which is fixed to the operating table. Previously, we had used the Zeem, which is intraoperative fluoroscopy. That's a machine that will take circumferential x-rays every 10 degrees and then will assimilate those pictures to make three-dimensional imaging. This is what computer navigation looks like at the field, where on the left you can see the surgical exposure, and the way this works is an array is connected to an immobile part of the body, so either a clamp on a pedicle screw or potentially with pins in the iliac crest. And then, at least with the intraoperative CT scan, and either CT or fluoroscopy does circumferential imaging, and then the computer is able to project based on these small silver balls depicted on the array, as well as all of the instruments, what the implant trajectory and sizes will look like. This is planning for pedicle screw placement, and you can see you can get very precise views, and it's really that cross-sectional view, that axial view, that is the most useful, because on regular x-ray you can only see AP and lateral, so you can see the spine from the side. You may be able to see on an AP view the circumference of the pedicle if you're lucky, but it's really that axial view that shows you the most important piece of information, which is the medial border. And in addition, the CT scan or the intraoperative navigation will allow you to place pedicle screws or select pedicle screws that are really optimum fit for each individual pedicle, because you want to try to fill the pedicle in terms of length and width as best you can. This is computer navigation for placement of a cage or an interbody device, again helping you pick a optimized trajectory so that you're not violating the end plates, and placing the cage at the correct depth, deep enough that you're avoiding neurological structures in the back, but not so deep that you're risking vascular structures in the front. There's a lot of literature on how good the computer navigation can make us, and the majority of those studies have demonstrated that the breach rate, meaning the erroneous pedicle screw placement, is 3 times higher with a freehand technique versus navigation technique. Here are 3 studies, each of them quoting about a 15% breach rate for freehand technique and about a 5% breach rate for navigation. I think those numbers are all a bit high. I think that when we were doing primarily freehand screws, we were noticing certainly single-digit breaches that we would potentially have to correct. And since we overcame our learning curve with navigation, our breach rate has been really 0%. This study has numbers that are not quite as good in terms of our success, but also noted that the navigation was a useful modality for optimizing screw size, because if you can make that screw as big as possible within the pedicle, then you'll get a better biomechanical construct. Interestingly, though, although the freehand technique may have a 3 times higher breach rate or error rate, there's never been demonstrated any difference in neurological injury between freehand technique and computer-assisted navigation. And the reason is the majority of pedicle screw breaches, when they occur, are of no significant clinical consequence. So, for example, a slight lateral breach, that's fairly safe territory. Nothing is going to happen in terms of neurological problems, but it's still worthwhile getting that pedicle screw in just the right spot, because you're going to get better biomechanical construct. Radiation exposure to surgeons and to staff in the operating room is also a significant consideration, and the surgeons who trained me actually had very little radiation exposure, because as they were doing their spine cases, they might take one spot x-ray at the beginning to confirm their level and a second spot x-ray at the end to check their work, and they could step out during that time. But the majority of us now are using some hybrid where we will do a freehand technique, but also use a fair amount potentially of intraoperative fluoroscopy, which exposes all of us to radiation. And particularly for minimally invasive surgeries, that radiation dose can be consequential. The lifetime radiation exposure for a spine surgeon is significantly higher than the radiation exposure to our orthopedic colleagues. And the number of cases that a surgeon needs to perform to start to reach a concerning occupational radiation exposure threshold is about where a busy mid-career spine surgeon would be in terms of annual number of cases of fusions. We have demonstrated that with computer-assisted navigation, you can reduce fluoroscopy time and potentially eliminate surgeon exposure or staff exposure to radiation. And although there is intraoperative radiation used during that case, the difference here is that the surgeon and staff can either step out of the room or step behind a lead shield while that radiation is occurring, so that the radiation exposure can be zero, as opposed to using fluoroscopy, where you may be directly in the radiation field as you're trying to place the hardware. There's also some evidence that there is decreased radiation exposure to patients. Even though we're using a CAT scan in the operating room, this is a low-dose CAT scan. The radiation is about 30% of conventional CT scan, and as compared to multiple AP and lateral fluoroscopic views, as might be needed in certain minimally invasive cases, you can reduce patient radiation exposure as well. There may be a cost savings associated with long-term use of computer-assisted navigation. Certainly bringing a navigation device in, it has a significant upfront cost, but then in the long run, you may be able to reduce that cost. There is evidence that navigation can reduce the number of reoperations because we are achieving more precise pedicle screw placement. And as I mentioned previously, pedicle screw placement that is suboptimal, hopefully not devastating, but if you are a medial breach contacting a nerve root, although that may not result in paralysis, you could result in new onset of radicular symptoms, pain, maybe numbness or slight weakness, and then that screw has to be repositioned. Or if you have a suboptimal biomechanical construct, the way that you've placed your hardware, the screws are not optimized within the pedicle, either too small or lateral breach and the fixation is not good, then that may increase their risk of developing non-union or hardware loosening, which can then be painful. And revision surgeries are very expensive. Navigation can also decrease your operative time. Now, there is a significant setup time before the case starts to get ready, but once the case is actually rolling, the rate of screw placement can be significantly improved. And just anecdotally, in my own experience, the pedicle screw placement by freehand technique might take several minutes for each pedicle screw to be placed by freehand with lateral fluoroscopy, which was my previous technique. But now with computer-assisted navigation, we can place each of those pedicle screws in about 30 seconds, sometimes with power to increase the rate of screw placement. And that adds up in a long case. So you do a scoliosis case, there may be several levels of hardware placement. You can knock off 45 minutes or an hour from some cases. And decreased surgical time is not just good from a cost savings perspective, because time is money in the operating room, but also less patient time under anesthesia, decreased exposure time, which may decrease blood loss and decrease infection risk. So we're obviously dealing with critical anatomy, delicate anatomy circumferentially when we're placing this hardware. Being extremely precise is critical. And so the benefits of computer navigation, optimizing screw placement, reducing radiation exposure to staff has made this a game changer. And I think, although there's certainly no standard of care now, I think that moving forward, this may become standard of care in the future. There are some drawbacks to navigation. As I mentioned, startup costs. These devices are extremely expensive, typically over $1 million. There's definitely a learning curve, and for me, that learning curve was probably around 30 to 50 cases before I started to feel that the computer navigation was more of a help than a hindrance. And that also goes for the OR staff as well. So if you have a dedicated team who does a lot of these, then you can really develop some efficiency. But if you have staff that's less familiar with it, then that can really create challenges during the case. As I mentioned, there is increased setup time at the beginning of the case, and that means increased turnover time, et cetera, as you're waiting for the additional steps of preparing the navigation and registering all of the instruments. There's more equipment associated because of the navigation features, and the machine does require maintenance. So with our brain lab that we're using now, it does require a few minutes of maintenance every morning to make sure that it is going to be reading accurately. And then the more complicated the device, the more prone it might be to breaking down. In terms of future directions, I think computer-assisted navigation has a lot to offer with oncology, tumor surgery, not only for hardware placement, but also so that we can ensure that we've made an adequate or complete bony resection. Minimally invasive surgery inherently has decreased visualization because you're using smaller corridors trying to be less disruptive to soft tissue. And so adding computer-assisted navigation to minimally invasive techniques allows you to safely place hardware by even a percutaneous approach. There's certainly a role for this in surgical training as well, and the training centers where there are residence fellows or medical students, the way that they use it will often be that they'll have their student sort of indicate intraoperatively what their planned trajectory is going to be based on anatomic landmarks, which is the traditional approach. But then prior to placing hardware, they can check their work, look at the navigation screen, and make sure that where they thought that screw belonged is really where it should go. I do think that everyone should learn how to place pedicle screws by a freehand technique before becoming reliant on computer-assisted navigation, so I'm a little bit worried that this could replace the art of freehand pedicle screw placement. Sometimes the machine can go down, or it may just not be available, and so you really need to know how to do a freehand technique. And I would say that this is really hybrid at this point. I use computer-assisted navigation as another adjunct along with neuromonitoring, along with that freehand feel of what it should feel like and look like based on anatomic landmarks to go down a pedicle. All of those things combined can help reduce those outliers. We are developing robotics, which essentially is an arm mounted to the table that can help make the trajectory of screw placement even potentially more precise. And then augmented reality, which means the surgeon wears some type of a visor, so they're able to simultaneously see the surgical field, but also see the imaging in front of them so that they don't have to look up at a computer screen while they're working. So this is a picture of me and Dr. Beck. We're doing a scoliosis surgery. This is the view that the anesthesia staff would have at the head of the table looking down, and then you can see the intraoperative CT scan, which the donut that you're looking through, and then the navigation instruments in our hands, and then the imaging that we're relying on in front of us. So this was a lecture about a very sophisticated machine. I think that this is a significant and important addition to spine care in this community and all of the patients that we are charged with taking care of. But I will submit sort of as my final remark that although bringing this machine to Plymouth has been one of my more important achievements in the last couple of years. I think that my most important achievement or my most important contribution to spine care in this community has really been to bring in the other clinicians who are up here with me today to build a comprehensive spine care team. Thank you.